Okay. Assalamualaikum warahmatullahi wabarakatuh. Have you guys had this sort of sessions with me before? Belum kan?
Belum.
No.
Okay, alright. Let's begin our session with Umar Fatihah. Then another issue is you've had this simulated long case before with other lecturers?
Ada.
Ada dengan siapa?
Mossad kan?
Dengan Dr. Mossad. Okay, Dr. Mossad suruh you kelak lah. Kan? Okay, only with Dr. Mossad eh? Okay. How it's gonna be today? So obviously this is not something that that is our usual norm lah. So this is a weird new norm that we are going to face. And sadly, this is at the very end of your posting kan. Tinggal berapa minggu? 2 weeks more. Okay. Alright. So how we're gonna go about it is because I'm gonna give you a scenario, and then what I want from you all is if you can like basically question me. So basically, you need to get the history from me. The idea is okay, how to say it? If you have a problem, I've told you before, isn't it? What's the objective of presentation? What are the objectives of any presentation?
To get the diagnosis.
Okay, so the first one is to actually to get to your provisional diagnosis, to focus to your provisional diagnosis, to sell your provisional diagnosis. What is the second objective of presenting?
Differential diagnosis.
To rule out your differential diagnosis. To rule out, to get to all your differential diagnosis and rule them out. What are the positive and what are the negatives for your differential diagnosis? And I have said to you how many differential diagnoses at least you need to have?
5, Doctor.
5.
At least 5. So you need to have at least 5 differential diagnoses. What is the third objective of any presentation?
Look up for complication.
Complications of the disease, because as I've said, all diseases have complication. Nothing in this world doesn't have any complication. What is the fourth objective?
Completion of treatment.
Look for the complications of treatment, because all treatment has its own complication. Okay, all right. Okay, so the idea is when you hear a problem, when someone tell you this is my problem, this is my issue, as a good clinician, the first thing you need to do is formulate your differential diagnosis, to formulate your provisional and differential diagnosis. Because without a good and robust differential diagnosis, you will never be able to ask the appropriate questions. You won't know what to ask. If you don't have the differentials, you won't know what to ask. Okay, only when you know the differential, then only you can know what are the questions to ask. Okay, all right. So, are you ready? Okay. Hopefully, it won't go too long. My aim is just a bit over 1 hour. Then we'll stop. Okay. All right. The scenario is this. There's this mother who brought his 5 years old child. Who brought her 5 years old child to the ward with complaint of reduced urination. 5 years old boy, reduced urination. Okay, that is the basic stem. So basically, what I want from you all is, what are the questions would you like to elicit? And then we'll go to what are the physical examinations that you would like to elicit as well. Okay, alright. So let's go about it. Kita go seorang-seorang. Kita mula dengan according to my list dekat dalam Zoom ni. The first will be Nurishman, and then Anis Amirah. After Anis Amirah is Aiman. After Aiman is Faiz. After Faiz is Wajihah. Lepas Wajihah ni nama tak keluar ni. Pakai spek, tudung warna hitam, baju warna brown ke apa.
Najlah.
Ha?
Najlah.
Najla. Oh, secret nama dia. Lepas tu, lepas Najla, Nur Afifah Muhammad Aris. Ni bukan Hidayah ke? Saya berada kat sini. Ha? Kak Hidayah PG Department kan? Ke you all ada nama Hidayah agak?
Ada
Ada,
juga
ada.
nama Hidayah.
Ya. Atau Hidayah yang awal PG Department tu. Okay, fine. Lepas tu Hidayah. Lepas tu Muhammad Azri. Lepas tu Madiah Safwanah. Lepas tu Lina Khairi. Lepas tu Suhaila Fauzi. And then Afiq Syahmi. Ada yang dah menghilangkan diri. Ada 2 orang. Lepas tu ada 16. Okay, let's begin. Nurishman, how would you go about it? So, again, the stem is mother brought the child, 5 years old boy, with complaint of reduced urination. What are the things that you want to ask?
In Malay or in English?
It's okay lah. You can even takalam Arabi for ما في مشكلة. تفضل.
Okay, Encik, berapa lama Encik perasan yang anak Encik ni ada kurang kencing ni?
Okay, you don't actually need to cluck like you cluck a patient. What I want is, what are the questions? What are the things that you would want to elicit? Okay, so your first question is how long duration? Okay, it will be 2 days. 2 days duration. Notice in reduced urination. What else you wanna? What else you wanna know?
Saya.
Belum, Nurishman. Satu lagi, one more.
Uh,
Don't worry, there will be plenty of things to ask.
okay. Dia setiap masa ke, setiap kencing ke dia kurang kencing tu, atau selepas minum air banyak tu baru, walaupun minum air banyak pun dia akan kurang kencing ke, atau bila macam ada time-time dia ada kurang kencing tu?
Okay, Anis Amirah, do you understand what he's trying to get? Faham tak dia apa yang dia nak?
Tak.
Maksudnya timing about the reduce urination tu, adakah setiap kali kencing tu akan reduce urination ke, atau maksud dia jumlah air tu kurang kencing ke, atau bilangan dia pergi tandas tu kurang?
Okay, soalan tu lebih mudah dipahami tapi tak berapa jelas lagi. So, what are you trying to elicit? You are trying to elicit are you trying to elicit frequency, reduce frequency or reduce amount? Is it?
Yes.
Kan? So you want to elicit reduce frequency or is it just reduce amount? Okay, so the better question will be, first you need to ask lah, apa yang masuk dengan reduce urination tu? What do you mean by reduce urination? Kurang kencing tu apa? Faham? That should be your first question. What do you mean by kurang kencing? That should be your first question. Then your second question will be, kurang kencing tu kurang kerap kencing ke, kurang kali kencing ke? Kan? Maknanya kurang nampak dia pergi bilik air untuk kencing. Ataupun is it memang kencing tu sekejap, sikit. Maknanya kencing tu kurang tapi jumlah banyak. Sekali kencing dia banyak. Ataupun dia kencing kerap tapi setiap kali kencing tu sikit. That should be your question. Faham tak? You clear? So your first 2 questions tu ambiguous, tak berapa faham. I nak jawab pun tak tahu macam mana. Okay. Then mother will say, okay, this child reduce in frequency and even reduce in amount. So biasanya usually he goes to toilet around 5-6 times per day, but now mother notice only probably 1 to 2 times per day for the past 2 days, and each time to just a very small amount. Okay, let's go to Anis Amirah. What else?
Dia anak pun ada mengadu sakit tak masa kencing.
Okay, that's good question. So what are you trying to elicit? So that is the general part of the question. Okay, kalau mak cakap ada, what are further question that you need to ask?
Sakit tu macam mana?
Okay, but again,
Demam.
sakit dulu. Jangan pergi demam lagi, sakit dulu.
Sakit masa kencing ke sakit setiap masa?
Okay, so again, what are you thinking? What are your thought process kan? Bila you tanya, when you ask about sakit, pain tu, what are you thinking? What are the differences that you are thinking? What are you trying to differentiate?
I'm thinking about maybe infection.
So UTI. So if UTI, usually when is the pain?
During urination.
During urination kan, masa urination tu sakit sebab dia inflame and the urinary tract is inflamed. So bila dia inflame, they irritable and they'll be painful. So pain is during urination. Okay, what are the other things that you are trying to differentiate? Apa lagi? What else can cause pain? Pain on micturition. Dysuria, the term kan? Stone.
I see.
Renal calculi. Renal calculi can happen in children. Can it happen in children? Can it happen in infants?
Yes.
Can is not a good question lah. Can, usually the answer is yes lah. Everything is can in the world. Nothing is cannot. Everything is can. So can is not a good question. Usually if someone asks you can something happen? The answer is can. Yeah, so can is not a good question. So basically, of course, renal calculi can happen. I'm not sure whether you know 10 years ago umur korang berapa 10 years ago?
12.
12.
Huh?
12.
12. Tapi 12 you dah baca paper tak? Baca paper dah tak? 12 years ago? 10 years ago? Tak baca?
Baca sikit-sikit.
Tak baca.
Tak baca.
Baca.
10 years ago, there's a scandal happening in China, basically, that relates to renal calculi in infants. Anyone has any idea?
No.
The issue is there is some formula milk punya company, they added melamine on their formula milks, infant formula milk. Melamine tu yang plastik tu kan, kita pinggan plastiknya pinggan melamine.
Warna putih.
So they added melamine into their formula, infant formula. So what happens is many babies at that time got renal calculi because of this. So pain during micturition, hematuria. So this is the issue. So even kat Malaysia pun at that particular time, 10 years ago, several of the companies, I won't mention the name of the company lah, still selling, but now they are okay. So if they had to pull out their formula milk because of this scandal. So my point is, renal calculi can happen in children. Can even happen in infant. Okay, so the idea, what you need to ask is there any pain? Ada sakit tak? And then sakit tu macam mana? Sakit macam mana is a bit difficult to ask. Why difficult to ask? Because 5 years old, you don't expect them to be able to pain. Sakit tu di sini, sakit tu memula-mula, sakit tu. No, 5 years old child, you don't expect them to describe the nature of the pain, isn't it? Kan? But then you need to ask also, when is the pain? Is it all the time? Is it abdomen? Is it during micturition? Is it before micturition? Or is it after micturition? At the very end of the micturition. Okay, Anis. Okay, let's go to next. Aiman.
Ya, saya.
What else you want to know? So the answer for this question is there is pain, but it is not. Mom says sometimes when the child urinates, there will be pain during micturition. Sometimes, not all the time. Okay, what else you want to ask? Aiman.
Puan, ada perasan tak perubahan terhadap kencing, warna kencing tu?
Perubahan
Ada nak
okay.
ada nampak merah ke?
Okay, the mother says there's no redness.
Okay. Ada bau
Tapi nampak
busuk.
pekat, nampak thick, nampak pekat, very yellow.
Memang pekat lah.
Oh, but then mom said sometimes it looks a bit red. Sometimes, not all the time. Sometimes.
Sometimes.
It's not very red, but sometimes it look reddish. Nampak sedikit merah.
Yang sedikit merah tu, boleh saya tahu tak Puan? Dia mula kencing tu dah memang terus merah ke sepanjang kencing tu merah? Ataupun
Okay,
last
yes.
kencing tu merah?
Yep, that's a good question. What are you trying to elicit? Huh? Dah. Okay. Aiman, what are you trying to elicit with that question?
I would like to elicit for any renal calculi, and also whether there is a problem, either it's in kidney, bladder.
So because the idea is if there is bleeding, you can assess where is the site of the injury, isn't it?
Yes.
So if the site of if the injury is in the urinary tract, at the urethra, for example, when will be the bleeding?
It will be at the start of the urination.
Usually it will be at the end lah kan. Maksudnya because of injury, bila dah urinate and then lepas tu dia akan injure kan. And then even kalau dah ada bleeding, kalau dah lama dia akan macam stop the bleeding, isn't it? Clotting process apa semua. But then when urinate, at the very end there will be bleeding. But if it's high up, if it's in the kidney, what's gonna happen?
It will be throughout.
The whole urine will be red in color. The whole urine will be red in color.
Yes.
Because it's high up. Okay. All right. And if it's in the bladder?
Maybe it will be in the middle.
So bladder usually sometimes sometimes kalau patient ada cystitis for example kan. So this sort of patient sometimes the bleeding it can happen earlier in the urination because blood is heavier, so it sediments below dekat your bladder kan. So bila you urinate, these are the things that comes out first.
I see.
Okay. Alright. So this patient, mother said the whole urine is thick and sometimes most of the time it looks red. The color is red throughout. Okay. Let's go to the next. Faiz.
Can we ask, anak pun ada berapa minggu ni dia pernah demam tak?
Oh, he has this low grade fever last week. Okay. Tak jumpa. Wait, give me a second. Guys, give me 1 second. Okay, sorry. Okay, let's proceed. Faiz, what was your question just now?
Demam.
Demam. Okay, so the mother says there's history of fever 1 week before.
1 week before. Ada pergi mana-mana tak untuk treatment? Pergi klinik ke ataupun demam biasa?
What do you mean by demam biasa?
Feverish. You only thought it's only feverish and it resolved by itself.
Okay, this is my point. demam biasa is something ambiguous because what meaning does it have? Does it have any value? Because demam biasa means so many things for different people. Faham tak? As when you ask question, so it's good to ask an open-ended question, but it's not good to ask ambiguous question. Sometimes there are situations when you can ask ambiguous question for certain things lah. Tapi in this sort of problem, if you ask like ambiguous questions, you won't have a good answer. You will have an ambiguous answer. So kalau contoh you tanya ada demam tu demam macam mana, demam biasa ke? Lepas tu kalau mak cakap demam biasa. Then how are you going to go about? Because it doesn't have any value. So the better question is ask lah the better. Okay. So first you ask ada ambil treatment tak? So that is good. Secondly, if you want to ask whether is it high grade or is it demam sikit-sikit, so that would be a better question. So demam tu demam kuat ke atau demam sikit saja? Because demam biasa means so many things for different people. Faham, Faiz? Okay. So mother says mother went to a GP and was told there is some it's not a high grade fever and there is sore throat. There is sore throat. Okay, let's go to the next. Siapa ni kat dalam my screen ni is Najla. Najla, what else you want to ask? Najla, where are you?
Okay. Hello?
Yes.
Yeah, okay. So I would like to ask, is it associated with facial swelling of the face? Swelling of the face?
Mother said sometimes, occasionally, in the morning, there'll be some puffiness around the eyes, but not all the time. What else you want to ask about that?
What?
What else you want to ask about that?
About maybe I think.
What else you want to ask? What else you want to ask, Najla? Sorry. Okay, Najla, again. What else you want to ask? What are the information you want to elicit?
Is there the swelling at other parts, like at the leg and also at the abdomen?
Okay, so mother says no. She only noticed at the face. Okay, let's go next. Afifah, Nur Afifah. What else?
Kan Puan cakap ada sakit tekak kan? Sejak bila lagi sakit tekak tu?
Last week kan?
Last week. Batuk semua ada, sesama.
Okay, mother says there is a bit of cough. There's a bit of runny nose as well at that time. Yusof, sini.
Sampai sekarang juga ke batuk tu lagi ke dah resolve?
Nope, only last week.
No. Dah resolve lah.
Resolve already.
Sesak nafas semua ada?
Nope, there's no shortness of breath. What else? Okay. Afifa, can I ask you, so by now, what are your differentials?
I'm speaking about post-streptococcal acute glomerulonephritis.
Okay, that is your provisional. What are your differentials?
UTI.
Okay, so ask about those differential. Again, as I said, good clerking, you must settle all the four objectives of objectives of presentation. You need to get to your, so these are all, so you need to get to your provisional diagnosis. You need to rule out all your differential diagnoses. You need to get to your, you need to make sure there's no, you need to look for the complications of the disease, look for complications of the treatment. Okay, so by now you should have a general idea. What is the difference? What is the provisional? I think you've got the provisional. What are the differentials? So ask about that. What are the complications of the disease? What are the complications of the treatment? Okay, fine. Afifa, what else? One more question.
About the feeding, is there any poor feeding?
What are you trying to elicit?
UTI can cause poor feeding.
Okay, so UTI, fever, okay. So, okay, fine. Mom says feeding looks the same. Last week, when the child was unwell, ada some reduced feeding last week, not now. Okay, let's go to the next. Suhaila. Lepas Suhaila ni siapa ni? Baju belang-belang, tudung hitam. You're next. Pakai jumper warna putih. Fine. You're next Suhaila lu. What else? Suhaila tak dengar. Tak dengar dia cakap apa kan? Anyone can hear?
No.
Apa? Let's go to, okay, Wajihala dulu. Suhaila, we can't get to Suhaila, tak dengar Suhaila cakap apa. I assume she's giving a very correct answer lah. Okay, Wajihala.
Saya nak tanya yang anak puan tu ada macam rashes tak dalam badan dia? Macam merah-merah tu.
Mother says no. Tak ada rash.
Ada sakit-sakit sendi tak?
Sakit-sakit sendi pun tak ada. Aktif,
So,
dia
dia
main
aktif
macam biasa.
Okay. Dia ada sakit perut tak?
Sakit perut tak ada.
Nampak perut dia macam ada mass, macam ada ketulan ke kat perut dia? Macam kembung ke?
Okay,
Ada perubahan
kembung is okay. Ketulan is not a symptom kan. Ketulan is a sign. It's not a symptom. You don't expect mother to palpate abdomen lah. Kan? So but you can ask about any abdominal distension. Okay. Fine. So mother says she doesn't think there's any abdominal distension. Okay, so Haila was asking, is there any nausea and vomiting? So, nope, there's no nausea and vomiting. Where are you trying to, okay, if the question about nausea and vomiting is good. Why? Why I'm saying that it is a very good question. Anyone has any suggestion? Kalau Suhaila, you boleh type lah, you tak boleh cakap. Anyone has any idea why nausea and vomiting is a very good question?
Fluid overload. Due to the fluid overload.
So fluid overload, why? What does it cause? What is the problem? How fluid overload causes nausea and vomiting?
The patient feel fullness.
Feel fullness because of fluid overload. Are you sure? If you drink too much, then but that's not fluid overload lah.
UTI ke?
Huh?
Rule out UTI boleh ke?
Yes, UTI causes nausea and vomiting. That is a known cause, kan? UTI causes nausea and vomiting. That is a known cause. Okay, that's one thing. What was your provisional diagnosis?
Sepsis
Post-trip
ke
tu
apa?
cocaine.
Post-trip.
Complication of
Glomerulonephritis.
post-trip tu cocaine.
Okay, post-trip GN. So how post-trip GN causes nausea and vomiting?
Complication due to hypertensive encephalopathy.
Yes, that is what I'm trying to lead. So, if you're thinking of post-trip GN and then the patient presented with nausea and vomiting, so you need to think of hypertension. So hypertension itself can cause nausea and vomiting. Furthermore, complication of that hypertension is hypertensive encephalopathy as well. So these are the things. These are the line of thinking that you need to go about. Okay, next, Madia Safwana.
Any dizziness or headache related to the hepatic. Okay.
Nope, there's no headache, no vomiting, no nausea, no vomiting, no headache, no dizziness. You don't expect a 5-year-old child to say headache lah. So they can say, sometimes they may say that there is headache. The thing is, in Malay, how would you ask the question? Headache and dizziness.
Anak puan ada mengadu sakit kepala ke?
Okay, so sakit kepala is okay. Sakit kepala means headache lah, kan? Dizziness? How would you ask? Huh?
Pening kepala.
Pening kepala. Okay. So this is my issue with our language. Bahasa Malaysia, bukan bahasa Melayu. It's not a very rich language. So certain terms are being used quite ambiguously with multiple meaning. For example, pening. Pening is one thing very ambiguous because you know headache, dizziness and giddiness are 3 different things. But sometimes pening can mean headache. Sometimes pening can mean dizziness. Sometimes pening can mean giddiness. So it doesn't carry much. It doesn't carry very strong value. Sama macam perkataan lelah. What does lelah mean?
Sesak nafas.
Does it mean asthma? Does it mean sesak
Asma
nafas?
boleh.
No.
It can even mean penat. It can mean busy. It can mean so many things. So lelah means so many things. Lelah mean kita berusaha keras pun boleh. Lelah buat kerja. So kita kena berlelah. Kan? So sometimes lelah means so many things. So kalau kita tanya mak, ada lelah tak? That question is an ambiguous question. Faham tak? That question is an ambiguous question. So if you want to ask, you need to ask something that carries value to your questioning. Okay, faham? Okay,
Faham.
so there's no dizziness, there's no giddiness. What else? Okay, kita sampai mana dah? Madia, next siapa? Nur Afifah. Nur Afifah dah kan?
Dah.
Belum?
Dah.
Susu lari dah lari. Najla tadi belum kan?
Najla dah.
Najla dah. Hidayah.
Hidayah belum.
Puan, anak puan ada nampak dia macam letih ke bermain? Masa sebelum ni dia aktif, lepas tu tiba-tiba beberapa hari ni dia macam jadi makin main.
For the past 2 days ni, the child looks a bit more less active.
Yang less aktif tu dia nampak tak macam dia sama ada dia sakit kaki ataupun dia macam malas je.
Nampak dia letih.
Nampak dia letih. Sakit kaki tak ada? Sakit kaki,
Tak
dia
ada.
mengadu sakit kaki ke?
Tak ada. Okay, what are you trying to elicit now?
The patient with acute glomerulonephritis can have fatigue and also they doesn't want to play due to the swelling.
Okay, fine. I was expecting a better answer. So pain macam yang your friend have asked kan, macam joint pain apa semua. So certain cause, SLE or henoch line can cause this sort of joint pain, muscular pain. I was expecting that answer lah. Okay, fine. Let's go to the next. Muhammad Azri. Lepas ni kita nak go satu round on physical examination pula ni. Tak sempat ni kan.
Okay, Encik saya nak tanya, kaki anak Encik ada bengkak-bengkak tak?
Tak ada, bengkak dekat mata sahaja. Only periorbital.
Okay, bengkak di mata. Lepas tu dekat bahagian abdomen dia ada sakit-sakit dekat certain bahagian ke? Dekat bahagian pinggang ke? Ada dia cakap tak?
Tak ada.
Tak ada. Okay. Perut dia tak ada kembung-kembung, tak ada?
Tak ada. These are question yang orang dah tanya dah.
Oh.
Okay, you were asking about pain dekat pinggang. So what are you trying to elicit?
It can be UTI ataupun it can be pyelonephritis, can be infection dekat kidney lah.
Okay, fine. Okay, anything else? One more question.
Sebelum tu nak tanya, patient ni dia minum air dia macam mana? Dia ada kurang minum air ke ataupun memang hari tu dia tak minum air ke?
Dia nampak haus, tapi
dia nampak haus?
Dia nampak haus tapi dia tak minum banyak, dia minum sikit je.
Oh, okay.
Okay, what else? Lina Khairi. Lina lepas tu Afiq kan?
Selain daripada nampak merah masa kencing tu, ada tak macam simptom pendarahan yang lain? Maksudnya senang bruises dekat badan-badan dia ke? Lebam.
Nampak lebam.
Okay, so easy bruising. So you're trying to get to easy bruising. Okay, fine. Mak kata tak ada. There's no bruises anywhere. Jangan tengok. Nanti kan internet tak boleh connect. Cuba check balik internet connection ni. Tengok. Ada internet ni. Apa lagi? Question. So there's no symptoms of easy bruising. In your line of questioning about bleeding, what else you can ask? This is a good line, This is a good line of thinking. So if you have a patient with red colored urine, so these are the things that you need to ask. But what else? This is a good. I think I can see what is your differential, but what are the other things that you should ask?
Spontaneous bleeding. Spontaneous bleeding.
What do you mean by continuous bleeding?
Spontaneous bleeding.
Spontaneous bleeding. So there's no spontaneous bleeding.
Kalau buang air besar ada macam pendarahan tak?
Tak ada. What else?
Muka patient ni ada nampak pucat tak?
Tak ada. Nope. In this line of bleeding, easy bruising, what else you need to ask? What else you can ask? Family history, is there any family history of easy bruising? You know this is a boy, isn't it? Kan? So kalau boy bleed urine, ada hematuria, it is good, you need to go about that. But then, so you need to ask about family history, because if it's hemophilia, how is it transmitted in the family? What is the genetic? What is the hereditary method?
X-linked recessive.
Huh?
X-linked recessive.
X-linked recessive. Sure.
Autosomal. Sure.
X-linked lah betul. X-linked recessive.
Autosomal.
It's not autosomal. Okay. Hemophilia. These are common question being asked in OSCE. OSCE kita boleh bagi ke hereditary ni family tree tu. Then tell me one of the common disease. Okay. So ask about family history of bleeding, easy bruising. Has the child have any surgery before? Surgery, and then any problem with prolonged bleeding after surgery, kan? Dental, kalau tooth extraction ke, ada gigi dia patah, cabut, dia susah nak berhenti. And then ask about circumcision as well. This is a boy, kan? Circumcision, kat Malaysia, what age kita buat circumcision?
12.
Kita generally in Malaysia we do circumcision much later. Tapi kalau ikut sunnah ni bila?
Lepas lahir.
Sunnah is 7 days lah, 7 days old. That is sunnah. The Prophet taught us if you want to do circumcision is done 7 days of life. Do you know other countries that practice the sunnah? All other countries in the world practice the sunnah. They circumcise their children very early on. Malaysia is among the few selected countries that do not follow sunnah. Because circumcision in Malaysia is just dia jadi ritual instead of proper Islamic punya practice. Kan? Islamic practice, you should do it early. If you look at American Pediatric Association, circumcision reduces the risk for urinary tract infection. But that benefit is only if you circumcise before 6 months old. Kan? So the benefit is circumcise early. So what I'm trying to say is, if you all have children later on, try and get them circumcised early, because that is sunnah and that carries the medical benefit of circumcision. Okay, so you can ask if the child is circumcised yet or not. So if the child is circumcised, is there any issue with prolonged bleeding and things? Okay, all right. Lina. Okay, next, Afiq.
Yes, Doktor.
Ya, what should I ask?
Boleh saya tanya, sebelum tu boleh saya tanya, patient umur berapa dan lelaki ke
5.
5 tahun.
Lelaki 5.
Nak tanya pasal bengkak tu. Bengkak tu ada rasa sakit ke, panas ke, macam mana?
Bengkak dekat mata dia? Tak ada sakit, tak ada panas?
Dekat muka? Oh, tak ada sakit.
Afiq ni lost ni.
Kencing dia ada berbuih tak?
Okay. Good line of questioning. This I like. So no. Mother says no. Tak nampak berbuih, tak nampak lebih berbuih pun.
Jadi berat badan ni ada perasaan dia naik tak?
Tak timbang. Siapa ada penimbang kat rumah? Any one of you has weighing scale kat rumah? Ada? Okay.
Jadi ni Cik datang ni sebelum ni pernah ada masalah yang sama tak? Maksud saya sebelum minggu yang lepas ni ada pernah banyak kali pergi hospital ke?
Okay, no.
Dia tak ada alergi apa-apa kan?
Ada.
Lepas tu saya nak tanya, sebelum ni pernah ada jangkitan kat kulit tak?
Okay, that's a good question. Dekat kaki dia ada lah, macam-macam sikit, parut dah.
Parut. Jadi dia tak pernah sakit perut lah sebelum ni. Lepas tu
okay, fine. Afiq, stop. Nourishment. What is your provisional?
Acute glomerulonephritis.
Why? Why?
Because he had history of fever and sore throat last week, and they already resolved. And then now he presented with oliguria, and also there's some Slight hematuria.
Okay.
Hmm.
Anis, Amira, differential. One differential. Why and why not? Tak dengar Anis, unmute dulu.
UTI
Okay, why and why not?
because there's in frequency and amount and also there's pain.
Usually if it's UTI, is it increased frequency or reduced frequency?
Increase.
Usually it's increased frequency kan. But the amount, the volume can be reduced, but it's increased frequency kan kalau UTI. Okay, what else?
And there's a pain during urination.
Okay, there is dysuria, pain on micturition. Okay, what else?
Also there's low grade fever.
That was last week lah. Okay, fine.
And
Negatives for
negative
UTI.
is there's puffiness in the eyes. UTI doesn't cause swelling.
Okay, good. What else?
And also there's a change in the color of your urine. UTI usually there's cloudy urine, and we have pekat, urine pekat.
Okay.
And also
okay, Aiman, another differential. Why and why not?
Another differential. Sebelum tu, saya nak tanyalah. Puan pernah dengar tak dalam family puan yang ada sakit SLE ke penyakit keturunan?
Okay, no.
No. Okay. I thought the growing arthritis is due to other etiology such as SLE.
Okay, what is SLE?
Systemic lupus erythematosus.
Yelah, I know. So, what type of disease? What is the family of disease? What is it called?
Autoimmune.
It's an autoimmune disease,
Okay,
isn't
autoimmune.
it?
Okay,
Yes.
autoimmune.
So when you go about asking about autoimmune disease, what are other disease other than SLE that you need to ask? There's so many autoimmune diseases, isn't it?
Yeah.
So if your family has this autoimmune disease, it's not just SLE. You need to think of something else as well.
Yeah. Okay.
Such as?
ITP, SSP.
ITP, not really.
HSP?
HSP, also not really. So thyroid, thyrotoxicosis, Hashimotosis, Graves' disease. Both Hashimotosis and also Graves' disease is an autoimmune disease. And Hashimoto's
thyroiditis.
So Hashimotosis, Graves' disease, diabetes, all these are autoimmune diseases that is associated with SLE. You need to ask about this. Okay, fine. What else, Aiman? In your line of thinking, autoimmune disease, why not in this patient? What are the negatives? Satu, tak ada family history, okay fine. Apa lagi next? Apa yang negatif lagi untuk this patient? What are the negative points? Anyone else? Boleh tolong Aiman? Negative points for autoimmune diseases?
Pasal dia tak ada rashes.
Tak ada rashes, okay fine, good. What type of rashes dia kalau dekat SLE?
Discoid ataupun
Discoid or malar rash. Okay, fine. Okay, what else Aiman? What else? You're going there, that's good. Apa lagi?
Malar rash.
Apa lagi negatif? So tak ada rash, tak ada family history lagi?
Tak ada family history, lepas tu
anyone else? Boleh tolong?
Arthralgia.
Arthralgia, okay. So it's not just arthralgia, it's also arthritis. Arthritis, arthralgia. Yep. Lagi. What else?
Alopecia boleh?
Alopecia, okay. Alopecia, okay. Loss of hair, okay, fine.
Oral
Okay,
ulcer.
Oral ulcer, yes, okay. Oral ulcer, mucosal ulcer, okay, fine. Lagi. Serositis. So serositis macam mana simptom dia? Serositis. Shortness of breath, basically pleural punya ni, pleuritis kan? Pleuritis ni bleeding pain during breathing kan? Apa lagi? Dia boleh jadi sinusitis, dia boleh jadi pericarditis, dia boleh jadi so many things. Okay. What else? Apa lagi? Satu lagi dia male. It's not common for things like SLE to happen in male kan? Kasi it's more of
Male.
more female. So these sort of things. Okay. Next, Faiz. Sudah dia dah berubah ni, tak apa. Faiz. Lepas Faiz Najla, lepas tu Wajihah. Differential, why and why not?
Nephrotic syndrome.
Okay. Why and why not?
Why? Because complaint of foaming of bubble formation.
Tak ada kan? Dalam differential tak ada.
Oh, tak ada.
Dia tak ada bubble. Tidur belaka semua ni. Why not? Why are you thinking about nephrotic?
Facial puffings.
Is it wrong to think about nephrotic?
No.
It's
Because
not wrong.
there's evidence of periorbital
Okay, sebab
edema.
okay, fine. Satu ada facial puffiness, satu lagi.
Lepas tu reduce in
Urine output.
urinary
Urine output, yes, very true. Lagi apa lagi?
and
Bleeding.
So nephrotic ada bleeding.
no.
Okay, what are the negatives for nephrotic syndrome?
Negative, no peripheral swelling. There's no finding of any weight gain.
Okay. What else?
No presence of foamy or bubbly urine.
Okay. Because nephrotic, there is a disease that we say nephrotic nephritic syndrome, where the patient presents with both features of nephrotic syndrome and nephritic syndrome as well. So they are both nephrotic and nephritic. So it is a double whammy punya sort of feature. Dia ada hematuria, dia juga ada proteinuria, and with all the complications of proteinuria. So this is nephrotic nephritic syndrome. Okay, so that's one thing. The other thing is you need to remember. I lost my line of thought. Okay, fine. Najla, next. Another differential. Differential, why and why not? Kita ada berapa differential lagi ni? 1, 2, 3, 4. Oh, banyak lagi differential ni boleh fikir. Lepas Najla ni Wajihah.
I don't know.
Mana pula I don't know?
Tak boleh fikir lah.
What else? What else should you think of?
Can it be due to the severe dehydration?
Yes, it can be because of dehydration, because mother says that dia nampak haus tapi dia tak minum, banyak minum sikit je. So it can be because of reduce intake. Okay. Why not?
Why not?
Also urine dia mak dia cakap thickened kan, nampak dark coloured yellow. Kan? So this dehydration punya ni. Why not? What was the negative for this?
Negative. Negative. Pain.
Pain. Huh? Pain. So sometimes thick urine, bila dia very thick sebab dehydrated, also it can cause pain.
Hematuria. Negative.
So usually it doesn't cause hematuria, like it shouldn't cause hematuria. Okay. Next, Wajiha. Other differences.
Can it be chronic kidney disease, doctor, due to underlying abnormalities?
Yes, it can be something chronic already because no one asked whether the patient has this urinary problem before or not. And so how long is it just this 3 days or is it before ada lama dah ada urinary problem? So it can be a chronic kidney disease. Okay, why not?
Because there is no presence of frothy urine.
Not really. Okay, if you were to examine this patient with chronic kidney disease, what would you expect?
Pale.
Huh? Pale? Okay, why pale?
Because patient with CKD can have anemia.
How they have anemia?
Kidney cannot produce hematopoietin.
Huh?
I cannot remember.
Erythropoietin. Ay, cuti lama sangat kan. Aduh, tak habis makan lemang lagi. Okay, fine. What else? Okay, apa lagi? Satu pain because of erythropoietin. Okay, lagi. What else? Chronic kidney disease. Anyone else want to help her?
Edema.
Edema, okay, fine. You can have edema, yes, true. What else?
Cello looking. Is there any?
Cellofacies, yes. Cellofacies is a sign of chronic kidney disease.
Chronic kidney disease.
Okay, what else lagi satu? Breathing ni macam mana breathing ni? What type of breathing? Someone was trying to say something?
Small breathing.
What is Kussmaul breathing?
Breathing due to metabolic acidosis.
Acidosis, yes. Acidotic breathing, Kussmaul breathing. So these are among the features that you can elicit by if you think of chronic kidney disease. Okay, fine. Next, Madia.
DDS.
Lepas Madiah ni Nur Afifah
Can still be renal stone.
Okay, fine. Why and why not?
Because of pain during urination.
Okay.
And there is reduced urine output.
Renal stone ada reduced output.
And then hematuria.
Okay. Why not?
Facial swelling. Renal stone should not have facial swelling.
Okay, yep. Lagi?
And then
No pain. Loin pain kan?
Usually they have abdominal pain, like suprapubic pain.
Okay, alright.
Okay.
Lagi? Okay, fine. Kita pergi next. Nur Afifah. Tadi Anis Amirah tak terlepas kan?
Dah.
Dah. Oh, okay. Nur Afifah. Another differential. Why?
So go for hematological causes
Okay. Yep.
like hemolytic uremic syndrome.
Yes. Okay. Good. So why and why not? What are the other added information? If you're thinking of HUX, what are the other added information you can ask or you can elicit
Any
from
bloody
bloody urine? Okay, there's redness in urine. Okay. What else?
any bloody in stool, enterocolitis like
Okay. Lagi lain?
Sign of anemia.
Or sign of anemia.
Yep. Anemia lagi?
Easy bruising.
Okay, easy bruising. Why HUS ada easy bruising?
Thrombocytopenia.
Thrombocytopenia. Okay, good. Yep, yes. So dia ada, sebelum easy bruising tu dia akan ada petty K dulu apa semua lah. Okay, what else? What else? HUS.
Diarrhea.
Diarrhea, okay, they can have diarrhea. Okay, what else? What else?
Abdominal pain.
Okay, they can have abdominal pain. What else? More important feature. Usually, they are more septic lah kan. HUS they are more septic. They will be more unwell. And HUS usually they'll be more unwell. Okay, fine. So HUS is a good line of thinking. What else? Hidayah. Lepas Hidayah ni Muhammad Azri. Lepas tu Lina, lepas tu Afiq.
Can it be diabetic nephropathy?
Diabetic nephropathy. Okay, why and why not?
Patient have hematuria and also patient papiness.
Okay. Good. Why not?
Family history.
Family history, okay, fine. Lagi, what else? So usually type 1 diabetes, family history tak sangat lah kan? Family history is more towards type 2.
Type 2.
And also
Okay,
there is no frothy urine.
Frothy urine, okay. What else? Diabetes.
Swelling only in the face. Usually diabetic generalized. No shortness of breath.
No shortness of breath. Okay, fine. What else?
No symptom of diabetic.
Okay, so symptoms of diabetes nak kena elicit. Okay, fine. Okay, Hidayah dah kata diabetes. Siapa next? Azri.
Ya, doktor.
What else?
Can it be thrombosis, doktor? Due to thrombosis, venous thrombosis.
Venous thrombosis. What venous thrombosis can cause hematuria?
It can reduce urination, but it cannot cause hematuria.
Venous thrombosis can cause oliguria.
Because obstructed, because blood is obstruct, cannot enter the kidney. Reduce perfusion. reduce
Okay, so venous
venous blood flow.
thrombosis. So cause basically nephropathy because of that. Okay, fine. Okay. Why and why not?
Why? Because it can reduce urination. Why not? Because there's no history of trauma. There's no general there's no facial puffiness. No mite, hematuria, no fever, and no frothy urine, no increase in weight, and no shortness of breath in this patient.
Okay, fine. Next, Lina Khairi, and then Afiq. Differential.
HSP.
Yes, I was waiting for that. Okay, so why and why not?
Because patient has URTI prior to symptoms and fever with hematuria.
Okay.
Why not? Why not? There's no rash, abdominal pain, arthralgia. Or edema as well. Edema dekat tempat lain.
Okay, good. Afiq, another differential.
It may be less common, but I would like to put PKD, polycystic kidney disease.
Polycystic kidney disease. Okay, so why and why not?
First, because he presented with hematuria, and then but the negative point is there is no masses. Lepas tu dia tak ada family history.
Okay, fine. Can it be liver disease? Everyone, can it be liver disease?
Liver? Can also.
Okay, so if it's liver, why and why not?
Coagulopathy, doctor.
Okay, so if liver, you can have other problem with liver, such as coagulopathy. What else?
Jaundice.
So yes, jaundice lagi. What else? Tadi kita tak tanya kan jaundice, sebab we never thought about liver kan. Can liver cause oliguria?
Can.
How?
Due to reduce urea formation.
Portal hypertension.
Portal hypertension, basically septic or illness itself, kan? Reduce protein. So bila reduce protein, you initially you lose, and then you'll be basically because of hypotension, underfill, kan? Okay. So can it cause edema?
Can
yes,
also.
it can cause. Yes, it can
Portal
cause
hypertension.
edema, kan? So negatif, maknanya tadi coagulopathy, jaundice lagi, apa lagi? What are the features of
edema,
hypoalbuminemia,
pain at the right.
Kalau chronic liver disease ada pain in the right quadrant, no kan? If you have a pain at right upper quadrant, fever, apa dia?
Cholecystitis.
Ya, benda deadline kan?
Biliary problem.
So, chronic liver disease. Can you tell me what are the stigmatas of chronic liver disease?
Spider nevi.
Spider nevi lagi. I hope you know how to examine spider nevi lah. Okay, spider nevi lagi.
Ascites.
Ascites, yes. Lagi?
Flapping tremor.
Flapping tremor, yep. Fine. Lagi?
Loss of
Jaundice.
axillary hair.
Loss of axillary hair, yep. Lagi?
Palma
Jaundice.
erythema. Palma
Palma
erythema.
erythema,
Palma
yes.
erythema.
Okay, good. Lagi?
Clubbing.
Clubbing.
Clubbing, yes. Lagi?
Dupuytren contracture.
Dupuytren contracture, yes. Lagi?
Splenomegaly.
Splenomegaly, yes. Will you have hepatomegaly?
Not.
Huh? Hepatomegaly ada tak ada kalau chronic liver disease?
Patutnya sering.
Ada.
No. No.
Shrink. Kenapa dia shrink? Aiman eh?
Iya
Why?
saya.
Kenapa dia shrink?
Sebab gitu
Cirrhosis. Yes.
Okay, cirrhosis.
Because of cirrhosis. Bila cirrhosis dia akan shrink. Okay, what else? What else? Ada lagi ni.
Gynecomastia.
Gynecomastia. Yes. Okay, lagi.
Testicular kecil.
Testicular hypo or hypertrophy?
Hypotrophy.
hypo.
Okay, yep. Lagi apa lagi? Kalau dekat abdomen, what can you see?
Ascites.
Kaput medusa.
Caput medusa. I was waiting for that. Caput medusa. Apa lagi dekat caput medusa lagi apa lagi? Satu lagi mana yang boleh nampak dekat abdomen dia?
Ascites.
Kaki dah sebut 3 kali dah sebut ascites. Striae.
That's right.
Right.
Okay. So chronic liver disease is another disease that you need to put under your differential diagnosis. Okay, fine. So again, this is the problem. So we as clinician, as medical student, lateral semua nak jadi doktor kan, tak ada yang nak jadi lawyer ke apa kan. So as future clinician, the idea is whenever you have a problem, the first thing you need to formulate is what are your differential diagnosis. Nampak tak? Bila you tak ada differential diagnosis, bila dah habis ni baru kita discuss pasal differential, baru you nampak apa benda yang you lagi nak kena tanya. Only when you have good differential diagnosis, then can only you ask appropriate questions. Kan, nak confirm your provisional, nak rule out all your differential, nak look for complications of the disease, nak look for complications of the treatment. Because there's so many things happen. For example, kalau you kata your disease, your provisional is a post-FGN. Post-FGN, have you got enough history to actually say this is post-FGN? Nampak macam okay, but have you look at the other complications of post-FGN? Hypertension punya issues, AGN can go into nephrotic. Have you gone to nephrotic punya issues? Kan? Hypertension ada complication dia. Have you assessed when the patient arrived in the hospital? How was the patient situation? Dia conscious ke tak conscious? Any problem with conscious level? Kan? Any blurring of vision? So we haven't gone through that. Kan? So you need to look at the complications of the disease. Also look for complications of the treatment, because you need to remember nephropathy can be caused by so many things, even things like drugs, kan? Or some food as well can cause nephropathy. Name me one food that can cause nephropathy. Makanan yang boleh menyebabkan nephropathy. Ada idea?
Makanan.
Jering is one food that is known to cause nephropathy. Dia ada nama dia. Jering ni, Melayu panggil jering lah. Kalau dekat Indon orang panggil apa? Jering ni. Indon panggil dia jengkol. So if you look at books, the term is jengkol nephropathy. So jengkol nephropathy is a known cause. Banyak study pasal tu. Jering is a known cause for nephropathy. Tapi budak-budak you tak expect lah makan jering. You all pun tak makan jering kot. Kan? So some food can cause nephropathy. Some drugs can cause nephropathy. This child had been ill 1 week before. So no one asked what medication that has been given. Kan? Apa mak dia ambil apa? Dia pergi GP tak pergi GP. Kalau tak pergi GP, sometimes dia buy drugs from shops, from sensei ke from mana ke. So sometimes all these things can cause problem. So you need to go about that. What ada? Can it be a complication of a treatment or of a medication? So you need to go through about that. Kan? So and then differentials, go through one by one all the differential. Nephrotic, so go through all about nephrotic. Why positive and negative about nephrotic? Liver disease, positive and negative. Hemophilia, positive and negative. HUS, positive and negative. All the causes of nephropathy, IgA, HSP, SLE, all the other autoimmune diseases yang boleh cause nephropathy. And go through positive and negative. And baru you boleh dapat. So this is the problem. Nampak? Okay, next. The other next kan dah more than it's already 1 hour 20 minutes dah. It's a bit
Physical
more than,
examination
tak apa, physical examination kita dah sort of cover. What next I want to ask you is, can someone tell me about the pathophysiology of AGN?
Mediated.
Macam mana siapa jawab tadi? Wajihan.
Wajihan.
Aku cerita kat kita sikit. It enlighten us.
Raja, kalau Raja.
Macam apa topak-topak. Wajihan. Aku topak.
Our body produce the antibody that actually attack our own antigen at the glomerular.
Tak berapa betul lah situ. Okay, fine. Orang lain?
Deposition of
immune complex.
Immune complex, ya.
Fine. So you start dari awal lah. So there is an infection. Infection dengan mendatang apa yang cause this infection?
Streptococcal
beta hemolytic apa dah?
Group B Streptococcus.
Group A.
ABHS.
Group A beta hemolytic. Okay, fine. So group A ni dia attack dekat mana? Kat mana dia attack?
Mula-mula dekat-dekat. Pasti dia masuk sistem ni.
So it can be biasanya is stroke lah kan, apa airway punya infection. Or kat mana lagi boleh jadi?
Dekat kulit ke apa?
Dekat skin. Tadi I mention patient ni ada banyak scar dekat kaki dia. What are those scar? Impetigo scar, yes. Impetigo scar. So streptococcus known to cause impetigo. So impetigo scar. So okay, lepas tu apa jadi?
And then goes to glomerulus.
Mana goes to glomerulus? Tunggu dulu. Streptococcus
okay.
What happened?
Complement activation.
Induce inflammation.
So bila ada infection, our body tries to fight the infection by
inflammation, induce inflammation.
Antibody.
So inflammatory process, complement activation. So that is why your C3 and C4 both initially will be low, kan? So lepas tu baru C3 saja. So your complement activation, activation of the inflammatory pathway, antibody formation. Okay, fine. Streptococcus ni ada berapa strain generally?
4.
Dia ada banyak gila strain, tapi yang we are thinking about dia ada 2 mainly is cardiogenic or nephrogenic, kan? So cardiogenic strain dia akan cause problem like
infective endocarditis.
No lah, not infective endocarditis.
Myocarditis.
Rheumatic carditis lah. So dia akan cause problem macam rheumatic carditis punya feature. Kalau cardiogenic trait. Kalau nephritogenik dia akan cause apa? Dia akan cause more of nephrotic nephritic punya problem lah kan. Okay, fine. So antibody formation apa semua. So and then what's gonna happen?
Binds with strep antigen.
Okay, lepas tu?
Form immune complex.
Before immune
Antigen.
complex kita tahu this streptococcus ni dia ada satu feature yang kita panggil dia ada molecular mimicry. So it mimics the structure of our own body. So yang tu yang jadi nephritogenik ni is because of the molecular mimicry. Kan? So body forms antibody, kan? It forms antibody, binds to the antigen. Lepas tu what's going to happen? Lepas tu what's going to happen? Lepas dia bind, antibody binds to the antigen. What's going to happen?
It will move throughout the body in the blood vessel and then it will deposit in the kidney.
Okay,
And cause inflammation in the kidney.
Immune complex deposition or antibody complex deposition. Kan? Dia deposit dekat mana?
Glomerulus.
Basement membrane.
Glomerular basement membrane. So dia deposit dekat glomerular membrane. So what's going to happen there?
Induce inflammation.
Okay, then induce more inflammation. Okay, what else?
Permeability reduce.
Huh?
Increase permeability.
Damage the glomerular basement membrane.
Okay, so damage the glomerular basement membrane. Lepas tu?
And then can cause increased permeability that causes the blood can pass through to the capillary.
Okay, what else?
And causes hematuria.
Okay, hematuria is not actually caused by increased permeability lah. What else?
Proteinuria.
Proteinuria is not actually part of proper nephritic kan? So inflammation at the glomerular basement membrane. This inflammation is the cause of the hematuria because of tubulopathy and also because of nephropathy. It causes hematuria because of inflammatory changes. One thing. Secondly is what does it affect? It affects the renal function. It affects your glomerular filtration because of the inflammation. It affects your glomerular filtration. So GFR reduces. It causes reduced urine output. So salt and water retention. And it activates your RAS activation. So RAS activation causes more salt and water retention. So what happens after that?
Hypertension.
Because when there's salt and water retention, you will be fluid overloaded, there will be hypertension. What else?
Pulmonary edema.
You can cause complications of fluid overload such as pulmonary edema. Yes, lagi. Basically cause all the edema, causes hypertensive encephalopathy. So understanding pathophysiology is very important. When you understand pathophysio, you know how you're going to treat. Biasa macam mana kita treat AGN? How would you treat? Huh?
Manage hypertension.
Okay, how would you manage hypertension?
We give ACI diuretics.
Huh?
We give ACE inhibitor diuretics.
Would you give ACE inhibitor as your first choice?
Furosemide.
Furosemide diuretic first.
Okay, you can give diuretic first. So furosemide is what type of diuretic?
Loop diuretic.
It's a loop diuretic. Okay, fine. Kenapa you nak bagi diuretics?
Increase urine output.
Fluid retention tu.
Because the problem is salt and water retention, kan? So bila you bagi furosemide, will it affect tak? Furosemide dia affect dekat glomerulus tak? So kalau problem is glomerulus dia yang dah jahanam kan. So if you give furosemide, will it help?
No, it affect at the nephron.
Furosemide acts at the loop. So even though glomerulus is the jahanam, it doesn't really matter lah, because it will still cause, you will still lose more fluid. Kan bila you bagi furosemide. Kan, so you need to give higher dose of furosemide lah. Okay, fine, you can give furosemide. What else you can give? Diuretics. So first diuretics, what else you boleh bagi?
Beta blocker.
Beta blocker. What's the first choice usually kita bagi?
Metoprolol.
Selalu kita start dengan calcium channel blocker lah dulu in children kan. Okay, anyone can tell me one type of calcium channel blocker, CCB?
Nifedipine.
Huh?
Nifedipine.
Nifedipine, yes, calcium channel blocker. So other than calcium channel blocker?
Beta blocker.
So usually beta blocker bawah lagi lah. So next after CCB,
ACE inhibitor.
Okay. Apa example of ACE inhibitor you boleh bagi?
Enalapril, captopril.
Enalapril. Okay, alright. Okay, so sorry lepas sebab budak-budak keticing. So apa tadi kita? Okay, so pasal tadi kita cakap pasal what else? So you nak bagi diuretics, you nak control blood pressure. What else?
Untuk supportive management, kita tengok, kita strict monitoring untuk dia punya fluid intake.
Okay, fluid intake monitoring, yes. How would you monitor? Would you restrict fluid?
No.
You won't restrict fluid. Why?
Just monitor the fluid intake. Sebab
we do fluid restriction to control.
Okay, so basically in AGN we need to restrict fluid. There is fluid restriction. How do you? Because the problem is salt and water retention, kan? Problem is salt and water retention. So obviously you will restrict fluid. So how would you restrict the fluid?
No salt diet.
Okay, fine. Okay, so untuk salt ni kita akan kata biasanya untuk children kita kata no added salt, bukannya no salt diet. So biasanya kita kata no added salt. Okay, water dia macam mana? Fluid. Macam mana kita restrict?
IO chart ke? Boleh ke?
Ha?
Ikut age. Kita ikut age.
Sebab tak baca protokol ni.
400.
So for AGN, you restrict fluid 400 mils per meter squared per day plus yesterday's urine output. 400 mil, 400 mils per meter squared per day plus yesterday's urine output. Kenapa 400 mil per meter squared? What is 400 mils per meter squared? What is 400 mils per meter squared per day?
fluid intake.
Memang itulah intake yang kita limit kan. You cannot
Up
be
to
more
400.
intake than that. Tapi kenapa 400 mil per meter squared? What is 400 mil per meter squared? 400 mils per meter squared per day is your insensible loss. 400 mils per meter squared is your insensible loss. Whatever you do, you don't do anything by breathing, by sweating, by whatever goes in your GI, kan? 400 mils per meter squared is your insensible loss. So bila you restrict fluid, you restrict 400 mils per meter squared per day for day 1, and then next day you plus urine output. So kalau urine output banyak badan, you restrict fluid. So minum boleh banyak ni sahaja. So strict input output chart, Mark boleh kira satu hari boleh minum 400 ml per meter square. You can kira lah berapa dia punya meter square dia berapa. Kan? And then you restrict kan. Plus yesterday's urine output. This is fluid restriction.
Fluid restriction.
Sampai bila kita fluid restrict? Biasa sampai the patient achieves diuresis. Bila dia start diuresis. Bila kita consider dia start achieve diuresis? What is the normal urine output? Normal urine output is 1 to 2 ml per kilo per day, per kilo per hour. Kan? So sampai dia achieve more than biasanya 1 ml per kilo per hour lah. Dia achieve more than 1 ml per kilo per hour, maknanya patient ni dah achieve diuresis. Bila patient dah achieve diuresis, you tak payahlah fluid restrict lagi. Faham? Apa lagi? You can do supportive treatment. You do bed rest, complete rest in bed. Jangan jalan-jalan supaya blood pressure dia tak shoot up naik. Kan? These are all the supportive treatment that you can give. Okay. So
Antibiotic.
Would you give antibiotic? Anyone, siapa yang setuju bagi antibiotik? Siapa yang tak setuju bagi antibiotik?
Setuju.
Aiman setuju dia yang cakap tadi. Najla, Anis, nak bagi tak antibiotik?
Bagi.
Kenapa nak bagi?
Kalau dia glomerulus apa? Yang streptococcal.
Doktor.
Kalau
nak tanya.
tak
Siapa nak tanya tu?
Anis ni. Ni sebab kita tak tanya pasal ubat tadi kan. So tak tahulah dia dah ambil antibiotik ke tak. Sebab kan dulu dia ada history of fever semua tu. I assume kalau tanya mesti dia dah ambil antibiotik.
Okay. So what was the point? What's the question? What's the point?
So kalau dia dah ambil antibiotik tu, yang ni sekarang ni dia datang sebab reduce urine output tapi dia tak ada demam apa semua.
Okay.
So maybe no need kot bagi antibiotik.
Kenapa dalam fix protokol?
Tengah teaching. So again, you understand the pathophysio. Is the pathophysiology is because of infection?
No.
No.
Yes. Yes, infection.
No, pathophysiology is because of immune complex deposition. So immune complex deposition. Kan? Immune complex deposition, immune complex is formed because of infection lah. But that is why sometimes, usually the natural history is fever or all this infection first, and then after that it happens. Usually after 3 to 5 days or after 1 week baru dia dapat symptoms of AGN because it's the complication of that immune complex deposition. So antibiotic is not actually indicated unless you think there is still concurrent infection. But you bagi antibiotic tu bukan untuk treat AGN but to treat whatever the remaining infection there is. Faham? So antibiotic is not necessarily indicated lah.
Okay.
I know dalam protocol ada mention tapi it's not we need to understand the pathophysiology. Okay. What else? What else? Treatment.
Diuretic, diet, supportive, fluid restriction, lepas tu tengok for ada symptoms of renal failure ke.
Okay, so you send for urea and creatinine kan? You send for urea and creatinine. So usually this sort of patient kita akan admit, kita akan keep dia in the ward until whatever renal failure settle lah. Urea normalize, creatinine normalize, urine output normalize. Kan? Satu lagi indication untuk kita nak allow discharge. Kalau dia still ada hematuria, would you allow discharge bila still ada hematuria?
No.
So masa bila you boleh discharge?
Tak ada edema.
Okay,
Clear urine.
Normalize BP.
So so for how long will you appreciate hematuria ni? Hematuria ni berapa lama?
Not sure.
Okay. So the point is macam ni, you can differentiate between gross hematuria and microscopic hematuria.
Okay.
So kalau gross hematuria, sometimes it may last 1 to 2 weeks. So we don't discharge patient until there's no more gross hematuria. Selagi dia ada gross hematuria, selagi tu kita tak boleh discharge patient. That's one thing. Secondly is microscopic hematuria can persist up to 1 to 2 years. So if you follow up the patient later on, you will see some more microscopic hematuria. That is okay, that is normal. Unless there is, kalau gross hematuria baru problem. Kalau microscopic, it's okay. Okay, clear. So kita keep patient dalam ward sampai satu dia achieve diuresis, normal urine output. Second, normal blood pressure. Third, normal renal function in terms of urea and creatinine. Fourth, when there is no more gross hematuria. So lepas tu kita boleh discharge patient. Okay. Fine. Next issue is, anyone can tell me, sekarang dah 1 hour 40 minutes, dah lama lebih daripada yang expected. Okay. Next issue is, I think I'm not going to go in detail lah, sebab dah lambat. I need to go somewhere. Pathophysiology of nephrotic syndrome. Another thing that I expect you guys to know in detail as well. Aku cerita sikit. Tadi siapa cerita tadi? Pathophysiology tadi?
Wajiha.
Najiha tadi. Okay, kita nak suruh siapa ni? Su ni siapa? Su ni tadi tak ada ni.
Sohaila yang mikrofon.
Oh, okay. Sohaila, mic dah okay dah? Oh, hilang terus. Ada. Kat mana ni? Dalam bas ke apa ni? Dia berjalan dah. Nampau tu. Okay, fine. Siapa yang boleh cakap sikit? Tak apalah, tak nak kacau Sohaila. Biar dia. Madiah. Enlighten us. Pathophysiology of nephrotic syndrome. Sohaila ni mana Sohaila ni? Madiah. Pathophysiology of nephrotic syndrome. Kalau tak dapat jawab, name me one person. Siapa yang you rasa boleh cerita kepada semua orang?
Maybe I can volunteer.
Oh, master.
But the others can back me up.
Bagi chance pada Madiah dulu. Dia tengah nampak nak jawab tadi. Kalau Madiah tak dapat jawab, baru Faiz ambil.
Ni Faiz lah.
Budak okay.
Dia nephrotic syndrome nak tahu dia punya etiology base, nak tahu pathophysiology based on its etiology, the causes. One of causes SLE. One of it. The most common one is minimal change disease. So minimal change disease is idiopathic. We don't know how it occurs. But if maybe due to SLE, we can know that there is a autoimmune deposition to the glomerulus. Then it can cause damage to the glomerulus and increase permeability. And then protein can be filtered out. Hence, there's presence of proteinuria and also hypoalbuminemia in our body, and also sign of edema due to due to the loss of protein.
Okay, orang lain. Hidayah. Mana Hidayah?
Hello? First, there is a leaky membrane in the kidney, and then the protein is lost throughout the kidney, reduce oncotic pressure, and then generalized edema.
Okay, better. Nourishment. Cepat. Pathophysial and nephrotic.
Because of there is permeability of the glomerular membrane cause it to because the membrane have like an ionic charge and then it will cause because albumin is negative charge kot. Lepas tu when there's a disruption in the permeability of the membrane, so albumin can go out because of
disruption
charge tu.
Okay lah. Fine. So pathophysiology of AGN, pathophysiology of nephrotic syndrome is something that you need to know. These are favorite questions in exam. Will ask you, tell us pathophysiology. So and even in theory in clinical exam as well, we can ask you, tell us about pathophysiology. If you understand pathophysiology, it will help you in terms of what are the questions you need to ask, how to manage this patient and everything. So understanding pathophysiology is important. Okay, generally, I'm not going to tell you in detail. Some of you has some patchy idea tapi tak dapat rasa betul-betul lagi. So if you're thinking about nephrotic syndrome, sikit lagi. We think about minimal change. So minimal change, what's going to happen? So basically, there is a problem with your podocytes of your glomerular basement membrane. So the podocytes of your glomerulus, a few things happen. First, increase the size of the podocytes. So increase the size of the podocyte, increases the pore in your glomerulus. Also, it changes the ionicity of your podocytes. So when they change in the ions, it attracts more albumin to cross. Increases the size of the pores, huge structures, molecules such as albumin can pass through. So it increases the permeability of the glomerular basement membrane. Will increase the permeability, it causes proteinuria. Causes proteinuria. Tapi there is no effect in terms of glomerular filtration, GFR is not affected. GFR is not affected. Sebab tu in nephrotic syndrome, you do not restrict fluid because the problem is not GFR. The problem is because of permeability, increased permeability, change in ionicity. The result is proteinuria. How much proteinuria? What is the value? So value ni pun kena tahulah. In milligram per deciliter, how much? 24-hour urine protein, berapa banyak? You test for urine protein creatinine index, what is the value? Kan? Baru you boleh diagnose. Kan? So proteinuria. So what is the result of proteinuria? Bila ada proteinuria, you so proteinuria affects your Starling forces. Kan? Starling law is for your cardiac. But Starling force is the plasma oncotic, plasma hydrostatic, and tissue. So basically, proteinuria causes reduction in your plasma oncotic pressure. Kan? Bila reduce plasma oncotic pressure and increase plasma hydrostatic pressure, so it will result in a shift of fluid from your intravascular space into your interstitium. Third space loss because of the disruption in your Starling forces. And so basically this is the underfill theory. So there will be fluid shifting from your intravascular into your interstitial space, into your third space. So dia akan jadi underfill. You will be edematous, but you will be underfill, and there will be activation of your RAS as well. Kan? So this is the theory. But you know nephrotic syndrome dia ada juga the overfill theory. So overfill theory is when there is more activation of your RAAS. So when there is activation of your RAAS, there will be salt and water retention. Salt and water retention causes overfill as well. So despite fluid going into your interstitium, you will also be overfill. The blood pressure will be high as well. In underfill, your blood pressure is low sebab fluid tak ada dalam intravascular. Sebab itu you cannot restrict fluid. Sebab itu walaupun di edematous, you tak boleh bagi diuretics. Sebab bila you bagi diuretics, dia dah intravascular depleted. Bila you bagi diuretics, you will lose more blood in the intravascular space. So you akan cause blood pressure to crash. So there's no role for diuretics walaupun dia edematous, gila-gila punya edematous, anasarca. Kan? You cannot give diuretics. Sebab you need to look at the fluid in the intravascular, not just the general overall fluid. Faham? So the point is understanding pathophysiology is very important. What I can say is AGN ke nephrotic, your pathophysiology grasp ni tak berapa strong lagi. Nak kena baca balik ni. Sebab AGN nephrotic are among the cases that will come up in your theory exam. Daripada MCQ kepada apa-apa sort of clinical theory exam, dia akan come up. Kita akan tanya sampai pathofisio, kan? It is among the commonest case yang you boleh dapat bila buat clinical exam pun. Mungkin you all tak ada clinical exam lah untuk this time around. I don't think we can afford to do clinical exam pada fasa COVID ni untuk third year. But you all are gonna be fifth year. You all takkan start as third year forever kan? Semua akan jadi fifth year. So, and then you akan pergi professional exam. So, among the cases yang akan datang for you in fifth year exam and also in professional exam is AGN and nephrotic. And I can assure you, we will ask about pathophysiology and all these things. If you understand pathophysiology, you know what questions to ask. You know how to manage this patient. Faham? Okay. It's already 1 hour 50 minutes. Okay, I think that's all that for us to discuss today. Any burning question? Belum kita stop. Any burning question? Tak ada, faham belaka. Semua jelas belaka. Clear. Tapi balik kena baca lah. At least what I want to try is at least to stimulate you guys that you don't know enough about AGN. You don't know enough about chronic liver disease. You don't know enough about nephrotic syndrome. So these are very, very common disease. Nephrotic syndrome, you need to know in great detail as well. Okay, alright. Boleh baca?
Baik doktor.
Kalau lepas session ni tak baca tak tahu dah buat apa lah. Okay, I think let's end our session with tasbih kafarah. Okay, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.